these slides, and a lot of trees have died with those things in front of you. I'm not going to get through the whole talk. The reason I have a lot of slides, my great fear is I'm going to run out and cut short, so I go over. So I've probably got the most perhaps interesting and topical topics first. So I'm a neonatologist at Counties Manukau DHB, so I'm clinical leader of the newborn unit. Counties has the third highest delivery population in Australasia, 8,000 plus deliveries. So we're pretty busy. My research interests are primarily in resuscitation, and it's really good to be here amongst medical people. $10 to the person that tells me where the nearest AED is. No.
Just one at the gym in the James Smith building.
No.
That's just around the corner, isn't it? And I see a sign.
MacPac. No, there isn't. The reception doesn't know where it is.
I've seen one here somewhere.
Yeah, that's right.
Yeah, it's been downstairs.
It's the MacPac shop at the bottom of the building. No, they don't know where it is. The reception doesn't know where it is. And according to the app, the nearest one's in the MacPac shop, and there's a countdown across the road. So there's no sign of it in this building. So just, I have a vested interest in this as I'm getting older. And, so if I do go down, what ratio are you going to do on me? Please tell me you know. Very good, very good. Now look, just concentrate on those chest compressions as I'll talk about before. I don't need the breaths too much. Just keep going on those chest compressions. But get that defib on me within 2 minutes. What are the chances of me going home from hospital after an out-of-hospital cardiac arrest? Alive. 30? Out of hospital cardiac arrest. Out of hospital. Yeah. 11. That's really bad. Time is muscle. Get that defib on me within 2 minutes, please. Assuming I'm in VF.
One of my staff members had a cardiac arrest last week, and she called the ambulance because her husband collapsed. She had a cardiac arrest in front of the ambulance officer who stuck the defib on, and she was resuscitated. She's in Auckland. She had bypass surgery on Friday.
Excellent.
Yeah, so
all right.
It does work.
So anyway, look, I'll move on from that. I'm nervous enough up here as it is. All right, so look, I begin these talks by apologising. This slide's a metaphor for your view of labour and delivery and the baby afterwards. And throughout this talk, I'm going to be giving examples of some of the worst case scenarios of various situations. So this is kind of neonatology and labour and delivery that I see, which is kind of shroud waving, I know, but so my view of sort of labour and delivery is more like that. It's a problem waiting to happen, and I realise that you see the normal side of labour and delivery, but as you can imagine, I see, I suppose, the more problematic side of labour and delivery. And the products of that, which is of course the newborn baby. So the topics I'm going to talk about, I know I'm going to step over the line, or not step over the line, I'm going to encroach on Cheryl's topic, but I'm just going to briefly talk about growth. I'm going to also touch on resuscitation, and hopefully these are all sort of basic subjects that you'll get some benefit from. I mean, we have lobbied you in the past for the sort of subjects you'd like, and these seem to be quite popular. So resuscitation, jaundice, congenital heart disease. You guys are screening for everything these days, aren't you? So you're aware of the screening for congenital heart disease program that's soon to be rolled out around the country. Do you know about that? All right, well, I'll brief you on that. This is the future. Hypoglycemia and dextrose gel, and another a group of small topics, and then very quickly, and I doubt if I'll get to this, touch on Group B strep and other congenital infections, or rather other potential causes of infection of the newborn in the first few weeks of life. So when I give these talks, I always begin with, I think some more people are about to arrive, Mariam. So I just pause. I always touch on the latest New Zealand birth statistics because I think these are fascinating. So the highest birth that New Zealand ever had was in 1961. That was the peak when New Zealand's population was only 2.5 million. So 65,000 deliveries. The next peak was in 1972, but then the latest one was in 2008, 64,000 deliveries. So we've never got to that peak that we got in 1961. And since then, other than for the year 2010, essentially the birth rate has started to go down, except for this year, it's gone up again. So I think it's fair to say that our birth rate is pretty much static, hovering around the 61,000 delivery rate. New Zealand women average just under 2 babies each, and that's precipitated down since 1961, although currently the Māori population, especially in Northland, have a slightly higher birth rate average per woman than other populations. So with those sort of rates of delivery each year, if you minus deaths from that, our rate of increase of population with births over deaths is just under 30,000 a year, which is just enough to sustain the population without immigration. But of course, immigration at the moment is going crazy. So we're having 60,000 immigrants per year. It's 5,000 a month. So that's what's producing most of the increase in the New Zealand population currently. So our delivery rates are pretty much the same. But the thing that is fascinating to me, and which is why I'm in a growth industry, is the demographics of the delivery population. So that's delivery years along the x-axis there, and that's births per 1,000 women down the y-axis there. And these are the rates of delivery for varying age groups. And the thing I want to point out is that somewhere between 2013 and 2014, for the first time ever, the group of 20 to 24-year-olds ceased being the third most common group to become the fourth most common group. So the highest delivery population currently is in the 30 to 34-year-old group. The next one is 25 to 29. And now the third group is 35 to 39. So the age at 20 to 24 has now dropped to fourth. And this is the latest statistics. And that trend has got even worse. Well, not worse, it's increased. So certainly this is reflecting the demographics of the New Zealand population. Most women are having their deliveries in that age group now. Which of those age groups has the highest chance of decreased morbidity for babies and mothers? Which of those age groups? What's the best age to have a baby in terms of outcomes and in mothers' outcomes? It's the 20 to 24, that's right. So this is just astonishing. The other interesting thing is that the teenage age is actually, that's pretty much has been static, but in the last statistic it's dropping. And of course the 40 to 40-year-old group it's remained pretty static. It's the same level as it was way back in the early 60s. It's remained pretty static now, but that's certainly a population that continues to have babies. So as a function of these demographics here, I'm in a growth industry. Because of course, as the maternal population ages, you're more likely to have more babies, more complications can occur. So the median age of all babies is 30 years. These are the data that I've already expressed on the previous slides. And these have been pretty much stable now, not for 10 years, but for 14 years. And the average age of delivery is certainly much older than it was 25 years ago. Median age of the first child, 28. So the median age of the average is 30, but the median age of the first child is 38, and that's also been stable now for nigh on for 14 years. The rate of multiple deliveries is going up. This is twins, triplets, quadruplets, etc. 1,000 in 1997. The rate now is over 2,000. Why do you think that is? It's maternal age. It's not IVF. It's maternal age. Multiple pregnancies, I don't need to tell you this, are highly abnormal pregnancies, high morbidity and mortality, much greater. It's a very unnatural pregnancy for humans to have, and that's a function, again, of the rise in maternal age, and of course, a great number of mothers, in summary, are greater than 30. So what's the evidence that mothers with maternal age are more likely to have complications? This is Scottish data, but it's from 2000. It really reflects what I'm trying to say. So more likely to this is comparing different age groups, 18 to 34, 35 to 40, greater than 40. In all these in all the sort of morbidities or complications of labour and delivery that we're concerned about, more likely to have induction of labour, more likely to have operative vaginal delivery, emergency caesarean sections, elective caesarean sections. Boy, elective caesarean sections increases my workload. Those babies come out with transient tachypnea of the newborn. They're forever tying up my level 3 cots in my unit. Babies born to elective caesarean section. So it's a nightmare for me because they tie up a bed for 24 to 48 hours just while they breathe out all that non-mobilised lung fluid. And of course deliveries before 32 weeks gestation. So that's points I'm trying to make, that I'm in a growth industry. It reflects the our current society and the rise in maternal age. And I'm sure you're seeing these sort of things in your own practice. All right, so, and this is the topic where Cheryl's going to sit up and take notes. It's just my take on growth. And again, going back to my earlier slides where I was talking about I see the worst side of things. So this is a baby that presented to us at County's Manukau DHB with, on day 6 of life with 18% weight loss. And these are some of the electrolytes this baby manifested. So serum sodium, which is a reflection of dehydration, 165 with a normal range there of 135 to 40. Thankfully, the normal sugar, but serum osmolality very, very high. And so this baby was essentially in shock. And this is a product, I suppose, of our society. Again, at this age, there's a lot of pressure on these mothers to, on the staff to discharge these mothers early, so early discharge. In this particular case, this was a prima gravida who kind of didn't know what normal was. And we're finding that the perception that the baby's actually getting a decent fluid volume is not terribly accurate. The baby may be sucking very well, strongly for 20 or 30 minutes. People are actually hearing fluid going down the baby's throat, but in fact the baby's actually not getting anything. So I'll talk about this in a second. So this is one case, and look, I suppose it was just a matter of time before this happened. This is the HDC report from this year, which was a baby that essentially came in with dehydration and hyponatremia, which died because it was essentially shocked. Its weight 3 days before discharge, and I don't know how old the baby was at this point of 3 days before discharge, showed 16% weight loss. That's assuming, of course, the birth weight was correct. That's also a problem. We need to make sure the birth weight is correct in order to get a decent feel for that. But let's assume it was. And then when it was readmitted 3 or 4 days after this discharge point, it had lost 22% weight loss and it was essentially shocked and passed away. The intracranial hemorrhage, that's a function of being shocked and dehydrated. All right. So I'm surprised this hasn't happened more with mothers that have gone home seemingly unsupported, but seemingly feeding very well. I've actually just missed out of a slide here. There was a second slide that before I came into this talk, I actually changed some of my slides and I knew this was going to happen. So I've cut one out and I think you've got it in the slides in front of you. The average birth weight of the New Zealand baby is 3.6 kilos. And of course, babies lose weight in the first week of life, as you all know. So, and I know Cheryl doesn't totally agree with this. From a neonatologist point of view, I'm a great advocate of the day 3 weigh. Now, I know that puts, there's an argument from, especially from the midwifery profession, that the day 3 weigh puts a lot of stress on mothers because they get a perception that they're not doing well. But the day 3 weigh to me is a flag that maybe the fluid intake hasn't been good. And if the weight loss at that stage is perhaps more than you're suspecting, and I'll use the figure of 10%, which I know is the figure the Midwifery College and Council have in your guidelines as a flag, it just might raise the profile that maybe this feeding isn't going so well and the lactation isn't being supported. The way I couch this to try and not make this a negative experience for the mothers is that I warn them that the baby will lose weight in the first few days of life, and if there is a weight loss on day 3, that's kind of expected, so don't be upset by that. But if the weight loss is considerable, to me that's a flag that maybe the lactation needs to be looked at more closely and lactation consultants sort of brought in trying to help the mother. Of course, this is assuming the mothers are still in hospital on day 3, because a lot of them have been sent home already and have the support at home from people such as yourselves. So I'm a great fan of the day 3 way. From my point of view, babies should be back to birth weight by hopefully day 10 to 14, and certainly by day 21. And once they are getting a decent amount of milk delivered, should be putting on about 15 to 20 grams per kilo per day, which is the amount of calories that they need to grow, which is just over 100 calories per kilo, which is about 150 mils per kilo. So again, I see the dark side of this, that's a feel that I have, that the day 3 way is a great flag for maybe the lactation isn't proceeding quite as well. Now, some of you might disagree with that, and this is the time to, if you'd just like to make that point, or wait till Cheryl talks later on today, maybe to discuss that further. But I think the day 3 way can be couched in a way that is not negative for the mother. All right, so the reason I've got this here is if you are having feeding problems and not very good weight gain, and combined with that symptom there, milk coming out the nose. Now, milk comes out the nose with babies that have intact palates, but just if you've got milk coming out the nose, and look, this happens all the time for us. In fact, the baby's got a cleft palate that hasn't been recognised, and the only way to really to diagnose that is to get out a spatula and a decent torch and have a decent look. So this is not a common occurrence, but it's a very easy. It's a very easy anatomical problem to miss because the outside of the face looks quite normal. If you are having a baby that's not feeding properly, believe it or not, that can be missed for quite a few days, and dare I say it, a week or two before actually somebody has a decent look. Just to point out that the cleft palate, there is a spectrum for that. Be also aware of the baby that doesn't have a uvula and the submucosal cleft. That's a little soft palate defect, which actually is closed over, but that soft palate's functionally not normal either, and that does need to be reviewed by the plastic surgeons or the nose and throat surgeons. That's not a normal palate, and that's associated with middle ear problems in the future. And of course, if you see any sort of thickened uvula, or certainly a bifid uvula, that's the same spectrum as that. That's also not a normal palate. So that also requires a referral, not necessarily urgently, but to other specialists. So torch, spatula, have a decent look. The thumb is not the proper way to examine the soft palate of a newborn. All right. Okay, look, very quickly, this is my own area of interest and research. As you're aware, every 5 years, the International Committee of Resuscitation reviews resuscitation guidelines for all disciplines, and of course, neonatology has been joined in that. And here's the new neonatal algorithm, which has the changes from the previous algorithm, which I've just highlighted there, which I'll talk in a little bit more detail in the slides coming up. Now, the first point I'd make, that this algorithm is not too much different from the algorithm that you're previously familiar with, and I also acknowledge, and we're responding to the criticisms of this algorithm from the Midwifery Council and the College of Midwives, that this very much reflects deliveries in secondary and tertiary areas. Of course, it doesn't reflect deliveries in primary areas or even in home birth situations. You need to go through I think look, we're still in negotiations how to phrase this with Elaine Gray and the College of Midwives, but you need to proceed through the algorithm to the extent of your scope of practice. But the things that we have included in this algorithm, I'll talk about this on the next slide, is the concept of the golden minute. A huge emphasis on temperature regulation. I mean, admittedly, most of the changes for the 2015-16 guidelines relate to the delivery of preterm babies, but not all of them. A big focus on temperature regulation, a big focus on making sure that your airway is established if you're needing to resuscitate the baby, and if you're proceeding on to the next stage of the algorithm, you need to be absolutely sure that you've done the airway properly in the first step, the previous step. There's no point in going on and doing, for example, chest compressions if you've never established an airway in the first place. And we've made things a bit simpler for the administration of adrenaline, which is probably, again, outside your scope of practice for most of you, delivering in primary and home situations. But I mean, it's pointless doing all these calculations when the chips of down everybody's resuscitating a baby. We've just made it very simple based on some gestation guides based on their average birth weight for giving just doses of adrenaline. However, the other emphasis is that these need to be given in an intravenous format, and again, that's going to be very difficult in the situation that many of you deliver. All right, so the golden minute. This has been introduced in algorithms throughout Australia, Europe and the United States. The concept is that by 1 minute of age, any newborn baby should have a heart rate greater than 100 and should be establishing a respiration rate. So by a minute after birth, no matter what the gestation. And if it hasn't done it by a minute, then some intervention needs to have been commenced by that stage. And I'm sure that, I'm not trying to teach you how to suck eggs, but I'm sure that you'd be aware of a baby that's not behaving very well or normally in the first few seconds after birth and would have instituted your resuscitation management, even if it's just airway positioning. But of course, if the baby hasn't started to breathe, it'll need the most effective intervention, which of course is ventilation, by at least 1 minute. So we've put that 1 minute in just as a landmark. By that stage, something needs to have happened if the baby's not doing it itself. And I'm sure you would have intervened earlier than that. The other change to the algorithms for 2015-16 is what to do to those babies exposed to meconium. Now, of course, in the old days, that's meconium aspiration syndrome on a chest X-ray. This is a big problem for me at Counties Manukau DHB. There seems to be something in the Pacific Island genome that makes babies pass meconium for delivery more than other babies. I don't know quite what it is. It may be related to maternal size. We have a lot of meconium aspiration syndrome at Counties Manukau. And I'm not sure if other midwives in this room who have a large Pacific Island population have a similar issue. So in the old days, we used to counsel that if you have a baby with meconium and the like, or we suck like crazy the baby when it's born, no matter what. So what's your practice now for babies that are vigorous if they're born through meconium? Do you suck those or not? No, you don't. Okay. Now the reason for that is there's been 2 trials, very large trials, admittedly done mostly in third world countries, but the data has been blessed by those that review these databases. So those babies that were born initially were born and then were vigorous, they were suctioned. Of course, there was no difference between the group that wasn't suctioned. They were randomised to suctioning or not suctioning. There was no difference in the meconium aspiration syndrome between those 2 groups. So then they started randomising babies that crowned, that were clearly vigorous. They were moving during crowning. So that's before they'd actually started to make some breathing. So then they suctioned those and randomised those to suctioning or no suctioning. Of course, there was no difference in meconium aspiration between those 2 groups. So of course, now the teaching is that we don't suction babies that are born vigorous through meconium aspiration, through meconium-stained glycol. We just get on and ventilate them if they need it, and if they're breathing on their own, they probably don't. So the great paradox is what to do to those babies that are actually born obtunded or flat. Well, that trial has now been done again in a third world country, which some people have a big problem with, but let's move on from that. That was a randomised trial of babies that were born non-vigorous. So they were randomised either suctioning, oropharyngeal suctioning or suctioning below the cords, or non-suctioning. And what do you think happened? Do you think the group that was suctioned below the cords did better than the other group? No, they didn't. Exactly the same. So it's exactly the same as for the data for the non-vigorous randomised trials. In terms of meconium aspiration syndrome, no difference between the 2 groups. In terms of death, no difference between the groups. And this trial was quite powerful, and then it had some neurodevelopmental follow-up, and there was no difference in that between the 2 groups. So the ill-call statement now for 2015 is that those babies that are born through meconium-stained glycol, if they're non-vigorous, we don't suction them below the cords either. Now I'm going to have to I'm just going to change that a little bit because not everybody's happy with that guideline. So this is what we're recommending, and the College of Midwives I think is just reviewing this at the moment. So if the baby is crying and it's vigorous, the airways are all going to be open, so you just need to support the ventilation. It might need some CPAP via a mask. It may need oxygen. Of course, well, I won't talk about oximetry. That's a whole other issue in these situations. I'm going to talk about it in cyanotic heart disease later on. But if the babies are born and they're flat, obtunded, and not doing anything. These babies are likely to be in trouble. They've been through the ringer during labour and delivery, and these are going to be hypoxic. So if you're skilled, in that you're used to looking down babies' tracheas with laryngoscopes, and you can do it in a slick fashion, the mantra is now, and this is what the Australians are doing when they're sort of on the end of a phone talking to babies like this that have been delivered in the Kimberley or some very, very remote area. If you're skilled, have a look down and suction below the cords and then the oropharynx, if you can do that efficiently, and then get on and ventilate. If you're not skilled, and that, I have to say that's probably most of the people in this room who are not used to using laryngoscopes and looking below the cords, don't do it, just get on and ventilate. This baby's had a hypoxic insult during the labour and delivery. You need to reverse the hypoxia. The only time that you should go back and perhaps see if the airway has been blocked in that situation is in fact you can't establish an airway. That's the only time we recommend you to go back and actually try and see if there's some particulate matter that's blocking the trachea and maybe needs suctioning out. So get on and reverse the hypoxia, ventilate the baby properly, and don't muck around trying to suction below the cords or in the oropharynx. All these babies that are exposed to meconium, as I said, have probably had a very rough time during labour and delivery. Keep them warm, but do not overheat them. It's quite clear that babies that are asphyxiated because we're total body cooling them now, if we make them hot, the neurodevelopmental outcomes are much worse. They need to be kept normothermic. This is different from cooling them for transport. They need to be kept normothermic. Make sure they're not overheated. Okay. And the other change in the guidelines for 2015, and I'm sure you've been telling us to do this for years, but of course now it's sort of built into the guidelines. All term babies, delayed cord clamping should be considered for all. Of course, the resuscitation guidelines are focused on babies that are needing help, and normal term babies, of course, don't need help, but they certainly have better blood pressure, higher hemoglobins, that physiological nadir of the physiological anemia of the newborn, which happens at about 3 months, is much less in these babies. They might get a bit more jaundice, but they don't seem to get enough more jaundice that warrants phototherapy. So in all well-term babies, that's fine. And while this is probably outside your scope of practice, of course, it's also a very good thing to do in preterm babies, and we'll define that as less than 35 weeks, not needing resuscitation. No matter what the gestation, nice long period of delayed cord clamping. Cord milking and cord stripping, do you understand the difference between those two terms? Cord stripping is where you cut the cord and then strip it, and cord milking is where the cord is still attached and you milk it periodically. As those are techniques that have seemed to have some traction around the world, but there's no evidence that they are anywhere near as good as just good old delayed cord clamping. Okay, these are measures that can be done if you want to quickly cut the cord and get the baby out if you've got any concern about it. Maybe just milk the cord or strip the cord. There's no evidence that those two techniques are particularly efficacious. Okay, so midwifery discipline's been telling us to delay cord clamp for centuries. We haven't taken any notice of you. Now we are. All right, so that's good. All right. Look, just quickly, chest compressions. The point I'm trying to make here is that this technique here is, when you're doing chest compressions, you realise what you're trying to do. You're really just trying to push some oxygenated blood from the left ventricle into the ascending aorta. You're trying to crank the heart going again. The perfusion of most other organs during chest compressions in adults and in children is pretty hopeless. You're not saving the brain, you're not saving the kidneys, you're just trying to get the heart going again. I just want to show you just how, if that's our mantra, I just want to just emphasise how a waste of time that technique is there, and I've just got a couple of slides to try and emphasise that. And of course, the ratio remains 3:1 for the baby in the delivery room. The evidence that that's a good ratio in the delivery room is very strong. The same baby on a postnatal ward at 12 hours of age, we don't know what the right ratio for that baby is. As with early discharge, if you have a baby that goes home at say 12 hours of age, presents at 18 hours of age to an A&E, it's probably going to get 15:2. The same baby on a neonatal unit, postnatal ward, if my staff go to it, will get 3:1 because that's what they're used to doing. We don't know which of those ratios is best for babies once they're born, but we know in the delivery room that that's the ratio the baby should have. And I think the question there is to use the ratio that you know best. It's the quality of chest compressions and ventilations that's more important than actually the particular ratio that you're doing. At what age do 15/2 become standard for every child? We don't really know that, and people say about a month of age, but that's based on no evidence. So anyway, why am I emphasising this? Well, look, this is the whole issue of chest compressions. So you're trying to create a coronary perfusion pressure, which is the difference between aortic end diastolic pressure and right atrial pressure. So this is a pig, and this is time along here, and this is pressure up here. So these are 15/2. So these are the chest compressions generating pressure on those that graph there. And this is the point here at which a breath is delivered. And I just want to point out that the coronary perfusion pressure, as soon as you stop, your chest compressions plummets. And this was behind the whole thing for adult resuscitation, that we should doing only compression only CPR. Of course, that's gone out now. You still need some breath built in there. But as soon as you stop your chest compressions, look, it takes about 5 more chest compressions before the coronary perfusion pressure gets back to where it is. So the point I'm making there is that chest compressions are actually very important. They need to be given consistently and of good quality, otherwise it's really not doing too much at all. So admittedly, this is a chest model, a pig model, but that's what you're trying to generate with chest compressions. So you're trying to generate decent pressure. And what I'm trying to show here, this is the difference between, just look at this graph here, this is time along here. So this is the different pressures being generated when you're comparing 2 thumb with the 2 finger method. So with the 2 thumb, it's these points here, that's time along there, that's pressure up there. So 2 thumb and suddenly 2 finger, the pressure just plummets. 2 thumb, 2 finger, 2 thumb, 2 finger, the pressure just plummets. With the 2 finger method, you're not actually generating decent coronary perfusion pressure or decent pressure at all. And this over here is just showing mean arterial pressure. This is actually neonates that they arrested in a PICU situation with arterial lines in place so that their blood pressures could be measured. So they alternated between 2 finger and 2 thumb as a sort of a little randomised trial. It wasn't a randomised trial. And what that's showing there is the blood pressure generated with the 2 thumb method is much better than the 2 finger. So that's kind of a waste of time. Look, you can do that from the head end. If somebody's managing the airway, you can do that from the head end. There's really no indication for that method there at all. I mean, firemen like that method because they can do breaths and carry the baby out of a burning building at the same time. And people say that you can actually you convert to that method if you're wanting to start to put umbilical lines in. But you can do that, the thumbs from the chest. Hands enveloping the chest and thumbs decreasing 1/3 the AP diameter. You have to push your thumbs down quite a big distance before you're going to get any sort of effective pressure generated. All right, that's enough of that. Any questions on resuscitation? I can talk for hours on resuscitation, as you can imagine. Oh dear. All right, jaundice. Look, again, I'm sorry if I'm teaching you how to suck eggs, but jaundice, again, causes us a lot of grief. So why do we worry about bilirubin levels in the newborn? And again, I'm starting with a case history. So this was a baby, good-sized baby. It was born, it had a low platelet count. But I think I know why that baby had a low platelet count, but it's irrelevant for this talk. Went home on day 4, clinically had mild jaundice. It was seen by a consultant, neonatologist, had mild jaundice, but seemed to be feeding okay, and then presented on day 7 of life with a serum bilirubin of 630. So I'm sure you can imagine what that is. And the baby was showing, now I have trouble pronouncing this, opisthotonus. Basically that's it there, it's U-shaped, it was fitting, all right? And that's a very pathological sign in any babies that are presenting with jaundice. That means that there is already brain damage occurring. Just to remind you of the encephalopathy that develops with hyperbilirubinemia when it's very, very high. There's a 3-stage encephalopathy. The first stage, you probably see, I certainly see this a lot. As soon as the bilirubin starts to get a bit high, the feeding starts to become poor because they become very lethargic. And that becomes a double-edged, it just goes round and round. The feeding gets worse, and they get drier and drier, the bilirubin just starts going up and they get more and more lethargic. So that's actually the first stage of the bilirubin encephalopathy. Of course, that doesn't actually cause any significant problems in terms of damage, but it's basically making the baby very sleepy. If the bilirubin remains very high consistently, these other symptoms start to deliver. Of course, the one that we saw on the baby when that first presented, and then after at least a week of having a very high bilirubin level, the more permanent changes of the bilirubin encephalopathy and brain damage start to occur. Muscle rigidity, irregular respirations, etc., etc. And the brain damage that this causes very much a motor brain damage, and it's irreversible. Unfortunately, quite often the IQ can be spared in children that are affected by this encephalopathy, so they actually have a normalish intellect, but have a choroathetoid spastic quadriplegia. Yeah, so it's not good. So this is why we get excited about bilirubins. So just going back to this baby, we kind of couldn't. We went through the potential causes for bilirubin of that level, which I'm sure you'll agree is very, very high. And I suppose I just want to talk about this to try and just reacquaint you with the causes of jaundice in the newborn baby. So we looked at the mother's blood group to see if there was an incompatibility there. So both the mother and the baby were group B, and of course just because those blood groups are the same, there can still be other blood groups, more esoteric ones that are causing the hemolytic setup, but the Coombs test was positive, the DAT test, I'll talk about that shortly. Other causes for jaundice, the conditions that cause high red blood cell turnover, innate conditions with the red cell itself, and of course the blood cells are turning over rapidly, there's going to be an increased bilirubin load from the breakdown products of that. So glucose 6-phosphate dehydrogenase deficiency, the baby had normal levels of that enzyme. Pyruvate kinase, normal levels of that. Metabolic screen with a Gus Ricard and extended was the same, was fine. So that was very mysterious. The bilirubin that high with a baby that's already showing neurological symptoms, we needed to get on and do a 2-volume exchange transfusion, and that was done, plus phototherapy, and got the bilirubin down to manageable levels. The first sodium that was done was high. It wasn't, horrendously high, and although this baby wasn't really weighed on admission, it was down 10% by the time it was first weighed, which is kind of the day after the volume transfusion. That was undertaken very rapidly. But unfortunately, this baby actually developed kernicterus. That's the basal ganglia damaged on MRI. So that white there, that's a sagittal scan. That whitish area there is the basal ganglia of this baby that has been damaged by the kernicterus insult. And while this isn't this baby, this is a post-mortem finding. This is the brain, or this is the middle part of the brain. That's in a coronal section, and that's the brainstem that's been cut through. And I think you can see that the nerve cells, nuclei, have been stained yellow by kernicterus, and that's nerve centres that have been damaged. And look, this baby hasn't done very well. It's now 9 years of age. They've moved to Tauranga. Look, cerebral palsy, choroathetoid, very bad. Look, it's got global developmental delay. The reasons for that are not clear, because I mentioned that IQ is often preserved in this, but this baby certainly has been very badly affected. And look, I won't go through the list, but this baby has been severely affected. So kernicterus is alive and well in New Zealand. Now, there was a whole period of time where we didn't seem to have kernicterus, and then we seem to have had a spate of them in the last 5 to 10 years. There was, in the 80s, it seemed to be absent, and then this neonatologist in Wellington reported this case that was published in 1997. And since then, those are the cases that we know about. So that Wellington case was a case of G6PD that produced a baby that caused kernicterus. A Christchurch case that was anti-Big E. I'll talk about that shortly. Admittedly, a case that wasn't actually it didn't happen in New Zealand, it happened in Tonga. It came to New Zealand. It was a 33-weeker with a bili of 268. An Auckland case, which I've just presented, and there's been a second case in Auckland in 2010, which is a baby that had numerous problems, but certainly the result of that is kernicterus. We audited the bilirubin levels at Counties Manukau over a 5-year period, looking at bilirubin levels greater than 375. And interestingly, we found in our Pacific Island group quite a high amount of jaundice, not necessarily caused by ABO blood group setups, but quite often. And there seemed to be an overrepresentation of some subgroups of the Pacific Islands. So a great deal of very, very high bilirubins in South Auckland, but we haven't had any kernicterus from this group. So it's almost as if in the Pacific Island community there seems to be some aggressive hemolysis can occur, but kernicterus has never resulted from that. And of course the other nervous system component that can be affected by reasonably high bilirubins is the auditory nerve, and again, none of these babies have come back with auditory problems. So there seems to be some protection there in the Pacific Island community. But we have a lot of very high bilirubins in South Auckland. I'd be interested to know if that's the case in other parts of New Zealand.